From New York Times Opinion, I'm Lulu Garcia Navarro, and this is First Person. There's a whole debate right now about the use of medication for obesity. But I think there's been something crucially missing in how it's being discussed. Let me start by saying I've been fat since puberty. Not just a few pounds here and there. I've been clinically obese for most of my adult life. I've done everything to deal with it. Fat camps when I was young, then crash diets, medical spas. I've had operations. About 40% of American adults have clinical obesity. And as anyone who is a person of size will tell you, there's a lot of shame and guilt around being fat. Most everyone sees it as an issue of willpower or motivation, and so did I. Then about 2 years ago at my old job, I had a life-changing conversation with Dr. Fatima Cody Stanford. She's a professor at Harvard Medical School and an obesity medicine specialist at Massachusetts General Hospital. It was a conversation about COVID vaccines and obesity, and during the interview, she told me this on air.
Unfortunately, we have these preconceived notions because we haven't recognized obesity for the disease that it is, that people that have obesity did this to themselves. And that is indeed a fallacy.
The fact that obesity is a disease was new to me. And still, many primary care doctors don't treat it that way, even as new weight loss drugs have been entering the market. You might have heard about some of them, like semaglutide, which is marketed under the names Ozempic and Wegovy. That's what I was prescribed soon after I first talked to Dr. Stanford, and it's been very effective for me. But even as these drugs become more popular, there's a fierce cultural debate happening about who should take them and when. Dr. Stanford's entire career has been at the forefront of the evolving science around obesity. She treats patients, conducts obesity research at Harvard, and we should note advises a number of pharmaceutical companies, including the one that makes Ozempic. So we put some of these questions to her. Today on First Person, Dr. Stanford on obesity, stigma, and Ozempic. Hi, nice to see you again.
Good to see you.
It is really, really great to see you, and I really appreciate you doing this.
Oh, thank you.
Okay. I would like to understand your story and obesity. How did you first come to understand obesity as a health concern? I mean, when did you first see it as an issue?
I think that I always saw it. If I go back and think about my family, I'm a Black woman born and raised in the South, particularly in Atlanta. I saw family members that struggled with their weight. Many were trying things like quick weight loss centers or, the grapefruit diet or all of these things that, were part of their recipe to achieve a healthy weight. And, at that time, I really said, well, I don't understand why this is so challenging, or at least that's how I thought about it. Is it really, really that hard? Like, can't we just exercise?
7, 8, now scissor.
Can't we just put on the Jane Fonda VHS?
8 and down. This is for the petrels. 5, 6.
And as I, kind of went through high school, I recognized that I had several friends that really struggled with obesity and even severe obesity. And I never, at that point, I don't think I judged them, but I always thought, well, can't we just do more? Can't they just join the track team with me? Can't we just do something better? Not recognizing that their journey was not like mine.
So when did you get interested in obesity in a professional context?
Yeah, I want to say that my really, really strong interest in obesity came as soon as I finished my undergraduate degree, and I immediately went to pursue my master's in public health at Emory. While there, I was working on several projects that were related to obesity within the Black community, particularly in Atlanta. One of the projects was focused on overweight and obesity within the Black church community in Atlanta. There was another project called Go Girls, like You Go Girl, which is, for those of you who know the 90s, a huge thing. And that was particularly focused on overweight and obesity and African-American girls. And then I did another project that was with the WIC program, so the Women's Infants and Children's Program, focused on those of lower socioeconomic status, looking at obesity within those communities.
What was the framing of these kinds of interventions? I mean, what were they telling people they had to do in order to be successful?
All of the projects that I were involved in were highly behavioral focused, right? Like if we can optimize your diet, right? Look at lean proteins, whole grains, fruits and vegetables, focus on activity and activity output. So a lot of focus was on just, behavior. And if you do these things, then you should be successful. And for those people that received the intervention versus those that did not, you would often see improvement in these parameters like weight status or blood pressure, things of this sort. But what would be disappointing is as soon as that intervention was over, you would see a reset back to where they were prior to the intervention, and sometimes even worse off than they were before. And this is when I guess I didn't know really what to do about that, but I started to recognize that, well, gosh, I'm not really sure that our results are sustainable. Like while we're doing it, and for those people that receive the highest level of intervention, great. But what happens after that? And I didn't really have an answer to that question.
Let me ask you this, because obviously you eventually head to medical school to become a doctor.
Yeah. Mm-hmm.
Was obesity part of the curriculum of what doctors were being taught to treat at that time? Because we'd already by that point been seeing a steady increase in the weight of the average person in the US since the 1980s. So was it something that was being sort of discussed as they were preparing you to treat patients?
Absolutely not. I know that's a very definitive and strong answer.
It really is.
It's with no ambiguity. So I would say absolutely not. I learned nothing about obesity and how to treat patients with obesity in my entire 4 years of medical school. It was not something that was tested. If it's not tested, it must not be important. And that was the reality.
After Dr. Stanford finished medical school, she started her residency in South Carolina, focusing on internal medicine and pediatrics. And she was frequently treating patients who had obesity.
For all of my patients that struggle with their weight, I would, give them dietary recommendations. I would give them exercise recommendations. I would do all of these things. And I saw very little change. I mean, occasionally you would have someone that would have some dramatic response, but that was like less than 5% of the time. And it was really my third year of residency that I realized my hyperfocus and my lack of understanding about obesity as a disease. I was rushing into the grocery store after a workout. So kind of just imagine me in my cute fitness outfits. And you guys, I wear some cute outfits. But anyway, running into the store.
I have no doubt.
And as I was running into the store, I see one of my patients. This is now my third year of residency, which means that she's been with me now for 3 years. So a pretty solid amount of time, right? As I'm running in, this is a woman, Black woman, who happens to have severe obesity. She was mid-40s at the time. She's about to check out, so she has a full grocery cart, which gives me an opportunity to do what most physicians aren't able to do, which is exactly see what she's buying. So I'm talking to her and I'm like, hey, she's like, hey, Dr. Stanford, and we're talking. And I'm glancing at the cart, trying to be inconspicuous, but failing miserably. And she makes an important statement that really changed a lot. And she says to me, see, Dr. Stanford, I told you I'm doing all of the right things. And so when you looked at her grocery cart, it was picture perfect. Every single thing that I had recommended to her over the last 3 years, all of the things that were high protein, good quality, no process, everything perfect as she was about to check out at the grocery store. And it was at that moment that I realized there's something else to this.
So you've been studying medicine for quite some time. Mm-hmm. And it wasn't until you saw this patient buying healthy food, essentially, what you would recommend, fruits, vegetables, mm-hmm. that you realized that it isn't necessarily a problem of what they are doing or eating.
Exactly. Something's wrong, and I'm not offering the best possible solution. So soon thereafter, at the beginning of my 4th year of residency, I came to rotate here at Harvard and Mass General in their obesity medicine fellowship program. And I spent my first month of my 4th year of residency here. And it was eye-opening. For the first time, I was seeing people use medications to treat obesity. Like, what is that? What does that even mean? They were using a comprehensive treatment strategy where they would focus on dietary interventions with the dietitians, focus on psychological health and implications with psychological health, focus on medications and medications that were used to address hunger cues, satiety cues, binge eating, all of these things, and surgical interventions that could have really broad implications in terms of addressing not only obesity itself, but chronic disease. I took this back to South Carolina, eager, ready to use what I learned. And when I got back, I was faced with significant resistance because when you're a resident physician, your attending physician, which means the one that's overseeing you, has to agree with what your treatment strategy is. And that often comes from them already being well-versed in that treatment strategy. So if I'm taking back how to use medications, these types of things, but they've never done it, they're not going to want me to pursue that as a treatment course, because if something goes wrong, it falls on them. So I had all of this knowledge, but that entire year, my 4th year of residency, I was unable to use any of those tools to help my patients because my attending physicians didn't have the knowledge that I gleaned in that 1 month of just rotating in obesity medicine here at Harvard.
I mean, I'm listening to you, and I think it's really important to note that physicians, general practice doctors are often the first ones to diagnose obesity because that's where patients first have contact in the medical community, but they don't have the knowledge that you were coming to have. I can speak to the shame and stigma and bias that many people who suffer from obesity face at the doctor's office. And one of the things that often happens is that doctors end up outsourcing treatment for obesity to for-profit enterprises. I'm thinking of Weight Watchers, fat camps, all these sort of interventions that put the financial and moral onus on the patient. How do you think about the way people who suffer from obesity have been told to lose weight and the business model around that?
I do think that the business model is set up that, people need to go out and seek their own care and get themselves together.
Now, whatever you want to eat can lead to whatever you want to wear. Weight Watchers new 123 Success 2000.
Going back to the 80s, the 90s, to the late first decade of the 2000s, it was a lot about that. Like really big at the time was Atkins.
Go online and get our free Quick Start Kit with 3 free bars. And you can be an Atkins achiever too.
Go do Atkins. Go buy those products. It'll work for you. It worked for this person and this person, so it should work for you. This is your problem. Come back and see me once you fixed it. And I think that's how people very early in life get set up with this resistance to the medical community.
So at this point, you're at Harvard, you are becoming a specialist in obesity. Mm-hmm. Knowing what you knew, dealing with patients every day who were telling you how hard it was to be taken seriously, did you try and change your profession and get the word out? I mean, every doctor takes guidance from the big medical associations. Where did they stand on this?
Well, it's interesting. I'm glad you brought this up. During my first year fellowship, it was a really pivotal time for me. I was learning so much about the care of patients with obesity, learning all of the modalities of therapy that we could potentially use. And it was at the end of my first year of fellowship that the American Medical Association actually called me up. And they called me up and said, "Hey, Fatima, we'd love for you to come to Chicago to do a talk on obesity as a disease." And I was like, okay, well, I've been a long-term member of the AMA by this point. This was now 2013. So I had to, in my brain, put together all that I kind of learned in a way that would explain to physicians. Because when you're at the American Medical Association, you have physicians from all states, all specialties, all there together. Think of it as Congress for doctors.
Good afternoon. Let's try that again. Good afternoon. Hi, I'm Fatima Cody Stanford. I'm an obesity medicine.
I gave a TED-style talk on obesity as a disease, really trying to use really simplistic ways of understanding the disease.
Is that everyone has a physiologic set point. So what does that mean? So that means that I will never be a supermodel. I will not be a size 0.
What I did not know, Lulu, is that this was the talk right before the American Medical Association's pivotal vote to acknowledge obesity as a chronic disease.
So you were basically presenting the case to make obesity a disease without really knowing it.
I had no idea.
Wow.
And the next day, the vote to acknowledge obesity as a disease actually went through.
I mean, as you signal there was a great debate about this. What were the specific arguments against it? What was at the heart of that debate?
A lot of people believed that obesity was just a consequence of other diseases, as opposed to a cause of the 200 plus diseases that obesity does cause. That was one of the arguments. A lot of people pointed to a lot of the behavioral studies that did demonstrate for some people that they had achieved success in interventions like Weight Watchers, like you mentioned earlier, or community level interventions. And so there was this pushback against this being a disease characterized by pathophysiology in the body. And a lot of that, I would say, came from the public health space. This idea that we can fix it if we just work harder.
Dr. Stanford, let me ask you this. What does that mean? When you say you began to see that obesity is a disease, what is it a disease of? I mean, do we know what causes obesity?
So I'm going to say it's a disease of the brain. And the reason why I'm going to say it's a disease of the brain, because the brain regulates how the body stores fat. The brain is the central operating system. If the brain's not there, the rest of the body doesn't work. So let's explain what happens. There are two primary pathways by which the brain will regulate weight. There is the pathway that tells us to eat less and store less, what we call the POMC or pro-opiomelanocortin pathway, or the AGRP pathway, which is the agouti-related peptide pathway, which tells us to eat more and store more. And we don't choose, and this is where the willpower issue goes away. My organs, my genetics, my environment, all of these things can play a role in whether I signal down the more desirable pathway or less desirable pathway. And so this comes the complexity of this disease that is obesity. Why do certain people signal one way and another people signal another way?
Well, help me understand this. You know, our genetics haven't completely changed in the past 40 years, yet we've seen this huge increase in the number of people living with obesity. So what's changed? I mean, are there environmental factors at play?
Absolutely. So we've placed our bodies inside of what we call this obesogenic environment. And this gets into those environmental factors and how they play a role, right? How has diet quality changed? How is our sleep quality changed? Our screen time, how does that disrupt or affect our circadian rhythm? We're supposed to rise when it's bright outside and go to sleep when it's dark outside. But I can tell you that most of us don't follow that as our inherent rhythm. So when we deviate from all of these things, put ourselves in this world that our bodies weren't really created to be in, it's going to lead to a greater storage of adipose or fat. It's stress on the body. And when we have stress, stress increases storage of an organ that has typically helped us out. And that organ is adipose or fat.
After the break, new treatments for obesity enter the picture. For as long as obesity has been a public health crisis in the United States, there have been efforts to treat it using medication. But there have been issues with the efficacy and safety of some of these drugs.
2 popular diet drugs were pulled off the market today,
linking the drugs to potentially fatal heart and lung disorders.
Confusion, memory loss, increased heart rate, and birth defects.
And you would expect a drug that helped people lose weight would lower those risks, in fact, increase them. And this confirms some worries about the drug.
As a physician, Dr. Stanford says not all of the bad press was merited. Even so, she says that it made doctors hesitant about the idea of obesity medication altogether. Then, just last year, the FDA approved a new obesity drug.
Good news. In the battle of the bulge, the FDA has just approved the first new weight loss drug in years.
And you're right if you're skeptical, but this could be the real thing.
It's marketed under the name Wegovy. It's a weekly injection that targets the areas of the brain that regulate your appetite. It's made from a drug that's been in use for a while called semaglutide.
So semaglutide or semaglutide is derived from a compound that was seen in lizards, actually. But
the Gila monster, I think.
Yes, the Gila monster. The Gila monster, to be exact. And so they derive this compound, which is a once weekly injection that does stimulate that part of the brain that tells us to eat less and store less. And when talking to people that for which are responders to this medication, and I think that's a really, really key part that I'm saying with people that are responders, because not everyone is a responder. These agents on average do have high degrees of total body weight loss. Semaglutide on average, 15.5% of your total body weight loss.
It was prescribed under the name Ozempic and given for diabetes for years, right?
Absolutely. And people always get very confused with this. If you're like, oh, that Ozempic, then I want to get on Wegovy, and I'm on Ozempic. It's the exact same drug, you guys. It's semaglutide. Just imagine one wears a blue jacket and one wears a purple jacket. And that's really, the difference between the two. What is the color of the pen it's injected from? Ozempic or semaglutide, when approved for type 2 diabetes, have been on the market. All of these medications always get an approval for diabetes first. Sometimes years before they get an approval for obesity.
So I will say I went on semaglutide and it was life-changing. I lost 75 pounds. It's completely changed my relationship to food. How have you seen this new tool help your patients? I mean, what is it like to have that as a doctor?
Well, what I enjoy, and I say that I'm the only type of doctor that has this pleasure to do this, is most doctors, you come in to see them, they add a diagnosis, 2 diagnoses, 3 diagnoses to your chart. When I treat the disease of obesity, I often am deleting diagnoses from people's charts. Maybe they had a history of diabetes or prediabetes. Maybe that's no longer present because their hemoglobin A1C is now normal. Maybe they had sleep apnea. We retest them, no longer present. Maybe they no longer have the same level of arthritis or polycystic ovarian syndrome, and that we could go on and on. So by treating the obesity, I'm often treating not only the disease itself, I'm treating all of these other issues. And I will tell my patients, and if any of them were here with us today, they would agree with this 100%. I never give them a target weight because I don't believe that there is a target weight for every person. I believe it's getting them to the happiest, healthiest weight for them. What does that mean? What weight are they able to live life and move throughout space with minimal limitations? Where is it that when I look at their metabolic health parameters, that they're all in ideal range? That's not a number I can define on a scale. For some person, that may be 300 pounds. Because for my patients that come into me at 500, 550, if I get them to 300, 315, those things all improve.
And I think that idea of different healthy weights for different people dovetails with this whole fat acceptance movement, which sort of highlights the very real problems with body mass index measurements and says that we need to be more accepting of different body types. There has been a pushback, though, on treating obesity like a disease from people in this movement who say that it does more harm than good. Is the movement mutually exclusive to how you see this issue?
It's interesting that you brought this up. And I've had some very recent interactions with quite a few people from the fat positive community, fat acceptance, health at every size community, whichever nomenclature you want to use. The underlying story that I hear is that, and where we agree, is that I should treat people with dignity and respect regardless of the size. Where we deviate is my recognition of obesity as a disease and their statement that, like, no, this isn't a disease. I don't agree with that. And so this concept of obesity as a disease feels more like a label, kind of like a say, oh, you have a disease. Look at you. You have a disease. You have obesity. Ha, ha, ha. But when they learn why I'm saying what I'm saying, there are people that may still push back, but there are others that may come to the realization that, oh, wait a minute, she's not saying this to say something bad about me. She's saying this so she can help me, or so I can recognize that this isn't my own choosing. And it's okay to accept going down that pathway without a focus on getting to a size 4 or size 6.
So you see obesity as a disease. This community wants people to be treated with dignity and respect. We've discussed how medication can help with some of this, but how many people who are eligible are getting prescribed medication for obesity in the US? I mean, are they getting the interventions that they need?
So I published a study actually in the Mayo Clinic Proceedings in 2021 that showed that only 1% of individuals that meet criteria for medication in the United States actually are getting them. That number may have improved slightly.
1%.
1%. A grand total of 1%. So we're, I think that we have a long way to go. I would love to continuously see these numbers change. A lot of people, that are hearing me speak or often will reach out on social media will be like, oh, well, it's because I'm just supporting the pharma companies. I believe in getting knowledge where it's from. If I can educate pharma companies about obesity as a disease, how it actually operates in real patients, not outside of just their clinical studies, then I will continue to do that. I want everyone to understand this disease, and I want everyone to recognize that we are not treating people for this disease like we do for other chronic diseases. We are never shy about treating patients with high blood pressure. We're never shy about treating patients with diabetes or high cholesterol. But when it comes to obesity, when I bring up a treatment, all of a sudden, this is a bad thing. Why wasn't it a bad thing for everything else? Herein lies our bias.
I'm thinking of your use of the word bias in all these different ways, from the medical profession, from society at large. And I'm thinking about the Ozempic semaglutide that's prescribed for diabetics has been in particular in the news lately. There is a shortage at the moment, and people taking Ozempic for weight loss are being blamed. And it's interesting to me to see how this has all been framed in the media, that somehow sort of overweight people or vain people are stealing life-saving medicine from diabetics. And there are a lot of articles characterizing obesity as vanity, not a disease. It's this myth that's embedded in our culture. Why do you think that disconnect persists? And why is there this shortage?
I want to state one thing out the gate. First of all, when we're looking at type 2 diabetes, we must recognize that 80% of people with type 2 diabetes have obesity. So when we talk about taking this drug away from people for obesity, when 80% of patients with type 2 diabetes have obesity, we are not understanding the realities, which is that many people with type 2 diabetes also have obesity and are often utilizing a medicine like Ozempic for its dual benefit, for the treatment of obesity and for the treatment of their type 2 diabetes. Number two, I think the misuse of semaglutide in places, and you guys know who you are, where you don't struggle with diabetes or obesity or even pre-obesity, which we'll call overweight, and you're going into special underground facilities, because I've heard of these, and getting, a dose of semaglutide for X amount of time so you can fit into your bikini for an upcoming trip. That's problematic. That's not the intent for these medications. Not only is that an issue in terms of the supply chain issue, the supply chain issue also just has to do with none of the companies had any idea that there would be the demand. And only now are they realizing that this demand will just continue to increase because people are recognizing that, hey, we can use these medications for the treatment of obesity or pre-obesity. And hey, in many situations, they do work.
Do we know the long-term effects, for example, of Ozempic, semaglutide, Wegovy? Because there's been some concern articulated that this is a relatively new drug and people might have to be on it for a lifetime. You're talking about long-term weight management. I mean, is that feasible? Do you have concerns around that?
No, I don't. Actually, we have a lot of safety and what we call CVOT trials that have come out for diabetes before Wegovy, which of course is still semaglutide, but of course under the trade name of Wegovy for weight regulation. These cardiovascular outcome trials have been ongoing and are highly effective in helping us to discern what we know about this medication in terms of outcomes, metabolic health outcomes. So when we see trials that demonstrate this time and time again, long-term trials that demonstrate this, the safety profile is stellar.
I guess what I'm asking here is that there's just been a lot of people who have said, all right, this has been approved for diabetics. This has been approved for long-term use for that population, but we don't really know the effects on people who are taking it solely for dealing with obesity.
So we do have, I would say, strong data suggesting how this will perform. So I would say that looking at a patient population with type 2 diabetes, most of whom have obesity, gives us a really great understanding of how this would do in patients that have, on average, lesser degree of illness.
You know, it strikes me that this conversation we're having is part of a bigger one about the role of medication in our lives. You know, I think in the past few decades, we've seen this cultural shift in how we think about certain kinds of health conditions and whether we should treat them with medication or sheer willpower. I'm thinking, for example, of SSRIs and other medicines that help with mental health conditions or medications to treat addiction. You know, Wegovy and Ozempic are part of that too. As a doctor, how do you see attitudes shifting towards medication in general? And is it a good thing?
I do think that on average, and that's across all medical conditions, that people have become more receptive to the idea that they would use a medication long-term, like you mentioned, SSRIs, which we're often using to treat depression. The stigma associated with the use of SSRIs has definitely changed in the last 20, 25 years. So if someone tells you, hey, I'm on Prozac, for example, people are like, oh, okay, well, that's great. Nobody looks at you in a negative way. I think that we have yet to get there as it relates to obesity or weight regulation. There are still a lot of people that when you bring up the idea that if these medications are effective to them, that this will be a long-term use scenario, that there's significant pushback. So much so that if the patient isn't thinking that as something that would like to consider if they're a responder, I will have us reconsider whether to use medications and not start medications. So those patients that come in and say, hey, I want to lose X amount of weight to go to X wedding, that's not the business I'm in. I'm in the business of improving health. And so I think that if we begin to shift our thinking in terms of a health thinking, and then coming back to reinvigorate whether or not this is a good thing or a bad thing, I think for weight regulation, for cardiovascular outcomes, this is a good thing.
Where do you think we are now in the treatment of obesity as a disease with these new medications coming online? I mean, do you see it as a tipping point?
I do see it as a tipping point. I just hope the tipping point aligns with our insurance coverage, aligns with equitable access to these therapies. And I do have a fear that this will become or create bigger and bigger health disparities. We know that certain communities, racial and ethnic minority communities, those from lower socioeconomic status, tend to have a higher degree of obesity at baseline. But these medications are out of reach for these populations that need them the most. And I think this will continue to worsen before it gets better.
So what would you like to see?
I would love to see, first of all, Medicare, get yourself together. We've been trying to get the Treat and Reduce Obesity Act across the House and Senate floor to cover anti-obesity medicines. When Medicare makes that change, we'll see the change over to private insurers, to Medicaid. Equitable access will become commonplace. We need everyone to take onus for the treatment of this disease, just like a primary care doctor would treat diabetes or high blood pressure. We need them to be treating obesity and not sending every single person to the specialists. I don't need to have the bread and butter cases. I need to have the cases that are more complex. But if no one is used to treating because no one's ever educated, going back to our initial thoughts, then we're going to continue to have these long waiting lists, including ours, which is over 5,000 patients here at Mass General for people waiting to be seen, because people aren't getting therapy outside of the specialty clinics or for-profit entities. And so we need to have better training and education. It needs to be commonplace in medical schools, nursing programs, PA programs, dietetic programs, and the list goes on.
So what would you, someone who's suffering from obesity, what would you recommend?
I would say that, first of all, number one, this is not your fault. It should not be a struggle. If you continue to struggle, despite all of your best efforts, do seek out help. There are over 6,000 obesity medicine physicians now in the country. Still not a lot of people when you look at the sheer volume of individuals that have obesity, but there are those of us that are here to care for you, to put your best self forward.
Dr. Stanford, thank you very much.
Thank you.
First Person is a production of New York Times Opinion. This episode was produced by Sophia Alvarez-Boyd with help from Derek Arthur. It was edited by Annabelle Bacon and Kari Pitkin. Mixing by Pat McCusker and Isaac Jones. Original music by Isaac Jones, Pat McCusker, and Carol Saburo. Fact-checking by Mary Marge Locker and Kate Sinclair. The rest of the First Person team includes Stephanie Joyce, Olivia Natt, Rhiannon Corby, Wyatt Orm, and Jillian Weinberger. Special thanks to Christina Samuelewski, Shannon Busta, Allison Benedict, Annie Rose Strasser, and Katie Kingsbury.